All right, let's get started. Welcome, everybody, to the February 18th, 2021 Rush University Medical Center Renal Biopsy Conference. Welcome back. We were off for a little last week because the Sunday before we did our biopsy conference through a GlomCon, which was a lot of fun, and we had 240 participants, just a little bit greater than our usual Thursday afternoon because it was on a Sunday at 10. And that 240 people covered 49 countries. So that was really exciting. And we're going to probably do that again, hopefully, if we're invited. Regardless, we're back to our regular time slot, and we've got a great case today. Today's activity code is 481509. As usual, it will be recorded and available on YouTube in a couple of weeks. And as usual, we don't have anything to disclose, and the patients have been de-identified in the case report. This is Dr. Gashi's case, and Dr. Shahzad's going to read the protocol. Asim?
So the patient is a 70 years old woman with a history of malignant thymoma, hypertension, and anxiety, who was admitted with bilateral lower extremity edema and shortness of breath. She was incidentally diagnosed with thymoma during a routine cardiac evaluation approximately 2 years ago. She received neoadjuvant carboplatinum and etoposide and radiation therapy, followed by a radical thymectomy. 1 year later, she developed recurrent right-sided pleural effusions and hydropneumothorax requiring pleurodesis and VATS. However, the pathology was benign on both the pleural biopsy and the pleural fluid cytology. She had been noticing worsening bilateral lower extremity edema for the past 2.5 months with ongoing shortness of breath and weight gain of 20 pounds. On admission, she denied using any nonsteroidals. Her main complaints were significant lower extremity edema and dyspnea mainly on exertion. Her past medical history was significant for malignant thymoma diagnosed 2 years ago, hypertension for the past 10 years, anxiety, and aortic regurgitation. The past surgical history was remarkable for median sternotomy with radical thymectomy, pleurodesis, and VATS. She had no known allergies. Her home medications included aspirin, rosuvastatin, toprol, losartan, and lorazepam. Social history was remarkable for being a former smoker. She smoked for about half pack per day and quit 50 years ago. She had no other drugs or alcohol use. She had no known renal disease as well. The VO system was positive for swelling in both lower legs and a weight gain of 20 pounds and anxiety. On physical exam, she had a blood pressure of 138/70, heart rate of 96 per minute. She was afebrile and saturating 98% on room air. She was a pleasant woman appearing her stated age, lying comfortably in bed with her feet elevated. Her head and neck exam was unremarkable, with a cardiac exam revealing a soft holosystolic murmur. She had normal S1 and S2 and a well-healed sternotomy incision. Her lungs were clear on auscultation with a soft, non-distended and non-tender abdomen. She had 3 plus bilateral lower extremity pitting edema, and neurological exam was intact. Her lab showed a hemoglobin of 15, WBC of 7,000, and a platelet count of 350,000 with normal differential. Sodium was 132, potassium of 5, chloride 98, bicarb 24, BUN 31, creatinine 1.12 milligrams per deciliter from a baseline of 0.8, calcium of 8.4, glucose 98, serum albumin of 1.2, total protein of 5.6. Liver functions were grossly unremarkable. Her TSH was 7.1 with BNP of 345. Total cholesterol was 254, triglycerides of 177, SDL of 64, and LDL of 155. ANA and anti-double-stranded DNA were negative. Complements, including C3, were 148 and C4 of 47. HIV was negative. Hep B surface antigen negative. SPEP and UPEP were also negative, with PLA2R receptor antibodies were pending. Urinalysis showed a clear yellow colored urine with pH of 6.5, SpecGrav of 1033. Dipstick had 1 plus blood, 4 plus protein, 3 RBCs, and 15 WBCs. She had rare hyaline casts with no RBC casts and negative for nitrites. Urine protein to creatinine ratio was 9.9 grams per gram. CT chest, abdomen, and pelvis showed stable, small right-sided pleural effusion, stable enlarged superior mediastinal paratracheal lymph nodes with pleural thickening, especially of the right posterior pleura. She had unremarkable kidneys, no hydronephrosis or hydroureter, and no suspicious renal mass. She subsequently underwent a renal biopsy.
Great. Any questions for Dr. Shahzad?
What was her race?
I'm sorry?
Sorry about that.
Caucasian.
What's her ethnicity? She's Caucasian?
She's
Okay.
white.
Yeah.
Anything else?
She had other age-appropriate screening, in terms of colonoscopy and everything.
As far as I remember.
As far as you know, up to date.
Yeah, because of her cancer history 2 years ago, she went
Did a full-
through a bunch of cancer screening,
Okay.
mammogram, colonoscopy, and they were all negative.
All right, Dr. Baxi, you want to start us off here? Give us a differential here.
Yeah. So, ultimately we have a patient here, elderly woman who's presenting with nephrotic syndrome. She has, hypoalbuminemia, edema, and 10 grams of proteinuria. And so in terms of the different, and she does have a little bit of AKI, her creatinine 0.8. Is up to 1.1. So she has AKI, but primarily we're really focusing on, the nephrotic syndrome aspect of this. And she has multiple different potential etiologies. She has this history of malignant thymoma, and seems like it was resected, a radical thymectomy, and she had, treatment for that. But there's always concern of recurrence and, that association with minimal change. So minimal change becomes on the differential. Other things for her, going through her history, she has a prior history of smoking, although, half a pack a day, quit 50 years ago. But, again, membranous is something else that comes on my differential in terms of nephrotic syndrome, especially with her, smoking history, and then also her age. Typically primary membranous typically appears in the 5th to 6th decades of life. So that becomes on the differential. Other things going down. And then FSGS is something I consider too. She has a little bit of AKI, primary FSGS. She's Caucasian. You can still have, if this is a little abrupt onset, 2.5 months, you can consider a tip lesion of FSGS presenting as a nephrotic syndrome and almost like a minimal change type presentation. So that's on the differential. And finally, given her age, looking at the SPEP, UPEP, and paraprotein amyloid or other paraprotein related disorders. And the SPEP and UPEP were negative, so that makes that less likely. So really that's kind of what we're dealt with. Looking at the UA, does the UA sway me one way or the other? She has a little bit of blood, in some whites, but no RBC casts. Minimal change. You can have a little bit of some blood, but typically when I see more blood and more RBCs, I think more of a membranous. Other clues to help kind of differentiate between minimal change, membranous, FSGS, which were on the top 3 of my differential, would be kind of the onset. It seems pretty sudden, 2 months. Usually for minimal change, it's a little quicker, but it's hard to tell exactly. Sometimes that's, can be misleading. We think it's a little, of course, over a longer period of time, or they say it's sudden, but it's actually been going on for a while, but seems to be a little more, not as acute, but, still 2 months is pretty a short period of time. And then looking at the lipid panel, she has, I think we've talked about this in our prior conferences in terms of cholesterol. And we see definitely major lipid derangements with minimal change disease, and her triglycerides are pretty high, cholesterol is up. And so kind of putting in terms of the onset, her malignant, history of malignancy, and then finally her age, the bimodal distribution of minimal change disease, we start to see idiopathic as we get older as well. So trying to put it all together, really my number 1 and 2 is minimal and membranous. If I had to choose one, the weight gain of 20 pounds seems to be relatively more sudden, elevated kind of lipid panel. I'll go with minimal change 1. Is it idiopathic or is it recurrence of thioma? That'll be the big question. And it could be either, really. But I think minimal change and then membranous will be a close second. Even though the PLA2R is pending, we could still have a non-PLA2R mediated membranous, and I'll put FSGS tip lesion 3rd. The AKI, if it is, minimal change, we see that a lot with, kind of quite significant nephrosis, and she has that. Her albumin is 1.2 and she has 10 grams. And so that may be related to that. But those are my top really three. Outside of that, I don't see much else, but I think it's really between minimal change and membranous for me.
Great. Dr. Corbett, you've written about minimal change in the adult. Why don't you pipe in a little bit here?
Yeah, I mean, definitely you can see it as February talked about in older patients as well as more commonly, obviously, in young children. I have to admit, as I look at this, I know February suggests that his number one is minimal change. I have to admit, I still think membranous has to be fairly high on the list. I mean, we talked about this once before, the cholesterol with minimal change, generally, you know, we see it in the 500 and 600 range. But as Dr. Glassick, I think, and Roger Rodby brought up recently, you know, there are patients who don't necessarily have to have that high of a cholesterol, even though we usually see it. What's interesting here is she's already on a statin, and maybe that's playing a part in controlling to some degree her hypercholesterolemia, because she's still got a high cholesterol, and off the statin it could be 400 or 500. I mean, it's 250 now with an LDL of 150, and then that may be a factor here.
Have you really seen statins work that well for hypercholesterolemia in nephrotic syndrome?
Well, there are some papers out there where they talk about improvement, but you're right. I mean, it may take the total cholesterol down by 50 or 100, and the LDL down by 25 or 50. It's, and so to say that this was, instead of 250, it was 350. You're right. I mean, it generally isn't that. I mean, it's, of all the things that are available, it's probably the best thing we have. But I agree. I mean, it's usually not that drastic. I'm just trying to account for why her cholesterol could be higher had she not been on the statin. I don't know how much higher it would have been. But
do you remember from your series? Do you remember from your series? I don't mean to put you on the spot, but an adult with minimal change with the cholesterol 254?
Off the top of my head, no. I mean, I wrote that paper probably 30 years ago now. And so off the top of my head, I don't really recall. What I do recall is, the response to therapy, which we kind of highlighted, but I don't remember exactly what the cholesterols were in the patients that presented. And the other thing I was thinking about as Prabir was talking was this whole issue of sudden onset. I mean, I still think, 2.5 months is fairly sudden in onset. But and you can see that with membranous as well as with focal sclerosis. And I think the tip lesion, as was brought up, is a good thought. Her creatinine is only 1.12, so it'd make it hard to think of something like collapsing, which would also have hypoalbuminemia of this degree and severe proteinuria. But I can't disagree. I mean, he did a nice job with the differential given her age and all the possible options. I think personally it's going to come down between membranous and minimal change disease at this point, and it's just a coin flip as to which one it really is, but it makes a major difference in obviously her prognosis and therapeutic outcome.
Anybody else want to differ?
I don't necessarily want to differ, but in a lot of these cases, we obviously want to link it to their underlying disease. And now, more in this modern era, it's not just linking it to the underlying disease, but also complications of therapy. I mean, we're seeing so much more excellent chemotherapy agents that are being added, the checkpoint inhibitors, immune therapy, and all the complications of that. But in this case, it doesn't look like her adjuvant chemotherapy is playing a role, because I don't know really of any platinum or etoposide-induced nephrotic syndromes, but we do always think about that. So I would agree with what they've said and kind of link it to original disease, with thus minimal change and membranous being on the top of my differential too.
The good news is it didn't cause her renal function to be worse.
Yeah,
the carboplatin.
It's almost like the HIV days, where everybody with HIV, it was just collapsing FSGS, and nowadays no one has collapsing FSGS, and everybody has complications of their HIV therapy. But in this case, again, like I said, it looks like it's a little bit more old school, and we may be heading back to just complications of our original disease.
Well, actually, nowadays everybody does have collapsing FSGS because of COVID, and Covan. But yeah. All right. Well, I think it's time to spin the wheel. Put the wheel up. I guess it's me.
All right, give me a second here.
Boy, you see, he wasn't in a big hurry to respin it again.
I'm happy to respin it. I just have to believe in the sanctity of the wheel.
Today.
Well, I don't know.
All right, go ahead and click on the screen.
Can you hear me, Pravir?
Yeah.
Okay.
Yep.
All right, so here we've got a nice core, a lot of glomeruli, and really not much blue staining material. A little bit here. You see my arrow okay?
Yep.
Yeah, good. A little bit up here, doesn't, and maybe a sclerotic glomerulus here and there, but actually looks pretty good. I would say minimal 10% or less fibrosis, if any.
Yeah. Right.
This is an H&E. We've got several glomeruli in the picture. Again, the tubules look pretty good. They're maybe a little separated, and that's always a possibility of edema. David can tell me in a second if he thinks they're a little separated here. And I'm reading into that because the patient is very nephrotic, and sometimes we can see some interstitial edema. David, do you think these are a little less packed than they should be?
Yeah. I agree with you. There's a little bit of edema there.
Okay, and the glomeruli, at least here, look, they look decent. I don't see any segmental scars. I know what's going up here. Is this a sclerotic glomerulus there?
Yeah. Two sclerotic gloms.
Yeah, so that's okay with her age, I think. But we don't see any segmental lesions. Certainly membranous was in the differential. We wouldn't be able to tell that here, or a paraproteinemia, probably not either. Nothing's obvious there. So a pretty good looking renal biopsy so far. Another H&E, actually for a 70-year-old,
Yeah.
looks pretty darn good.
It's just PAS.
Is it? I'm sorry, PAS. And the cellularity looks pretty good. It's not as easy to tell with the PAS, but it looks pretty good. The mesangium doesn't look expanded. The capillary loops are open. There's a little something going on here, but I don't think it's anything. I don't think it's a scar or a adhesion. This tubule looks like it might be have a little ATN here.
Right. Yeah. The brush border's lost. Or
Yeah, brush border's gone. So we've got a little bit of ATN and a pretty normal looking glomerulus.
And then there's an arterial down at the bottom with some hyalinosis.
Yeah, it's not actually that bad.
Keep going to the bottom left. Keep going. Yeah, that and below it. And yeah.
But that's not feeding this glomerulus, is it?
I don't know. Maybe it takes a right turn. I can't say.
Okay. Yeah. Well, I wasn't even looking down there, but yeah, this is, there wasn't much here.
It goes off up to the left because actually, look, it connects up to the left. Yeah, there it goes.
Yeah. Okay. Whatever you say, David.
Yeah.
And here we have another glomerulus. I think this is just fracture from the tome. I don't think this is anything fractured cast or anything going on. They're looking at the glomerulus again. Some mild mesangial hypercellularity here, but nothing impressive. Maybe a little more thinned, some more of the thinning of the tubular basement membrane, the tubules. But I don't really see any atrophic tubules here.
Yep.
Is that just artifact, David?
Yeah. That's from the microtome.
Yeah. Okay. Here we have a nice silver stain. Again, this is beautiful because you can really see what's going on architecturally. The mesangium, if expanded, is very minimally expanded. We're looking for holes, splits, duplications, at least at this power, I don't see anything. I saw one loop here that seemed kind of thick, but by itself, I don't think that meant anything. It was probably its cut. Something like this could possibly be a spike. Something like this could be a spike, but I don't think it's enough yet. I think maybe we'll go up on the higher power. Certainly don't see any breaks. Nothing to suggest amyloid so far. Nothing to suggest a segmental scar. So right now we're kind of heading towards either a mild membranous or a minimal change.
Yeah, even in the en-phos basement membrane, you don't see any holes. Really.
That's a really good point. Yeah, you could see. Yeah, that's a really good point. And that's probably what's going on in some of these that look a little thicker. They're really just the way the basement membrane is cut, kind of at an angle. Here we're looking at the tubules again. Here's some sloughing and probably represents what would be a granular cast. Eventually, glomerulus up, end of a glomerulus up here. They don't look too bad though. And here they're really well packed, and there's no interstitial nephritis and no real tubular atrophy. So I guess just some mild ATN, David.
Yep.
Yeah. And now, I mean, Pravir talked about that, and the association of ATN with minimal change and the acute onset and its association with the degree of hypoalbuminemia. So it's no surprise. Of course, whenever you see AKI with a GN, you don't know if it's the GN or if it's, something secondary like ATN. And I think that's probably the case here. And it's very mild ATN. At least clinically, it's mild ATN. Pathologically, it's also mild, but that doesn't always correlate with clinically at all. Sometimes we can see really significant ATN clinically and very minor tubular abnormalities and a couple mitotic figures here and there. So IgG is completely negative, which takes membranous out of the discussion. I assume Congo red and everything was negative. So completely negative immunofluorescence leaves us, at least right now, from where we are with minimal change, and we'll try to see if the EMs continue to support that histopathologic diagnosis. Here's a mesangial area. These are dark areas, but I don't think these are electron dense deposits. They're actually a little dark. I think this is just cell processes or something.
Yeah. Right. Correct.
Yeah, the mesangium looks a little expanded here, but not, maybe not. And then they give a nice takeoff of 2 loops here, and the loops we'll see on higher power, but I don't see any spikes or holes or deposits. Looks a little darker here, but I think that's probably artifact. And again, we'll go up on the power, but at least looks pretty normal. At least, and here, the foot processes are fairly significantly effaced, probably, almost completely effaced.
Yeah, and on the loop over at 3 o'clock as well, you can make out,
3 o'clock, I'm sorry, here.
Yeah.
So David, what is this? Is this just this little dark kind of
Yeah, I think it's artifactual, as you said. Yeah.
Okay, good. It's not a dense deposit disease that's going to trick me and make me look silly. So here's another loop. This is the blood space. Here's the urine space, blood space, and urine space. And here we can see foot processes are really completely effaced. Maybe a rare podocyte here, foot process. And you can see the fenestrated endothelium. But again, if you follow the basement membrane out, there's no deposits, there's no spikes, there's no holes from even an old membranous. So I think this is really what we're going to find. Measured, it's 284. That's normal, so it's not thin nor thick. And this is a really nice view here of the foot process effacement, which is really complete and very nice and kind of fits our diagnosis, clinical number 1 diagnosis by Dr. Baxi. These here, you might get the impression that there's something, but this is, and this is probably here too. These we used to call LBDs. Steve, you want to tell us what an LBD is? Well, I'll tell you what an LBD is. It's
I know
called
that one. It's a little black dot.
Little black dot. Yeah, I thought I'd have some fun with that. So these, not everything has meaning, so we call these little black dots.
Yeah.
So my diagnosis is, I guess, minimal change disease. It's not focal sclerosis. It's not tip variant. It looks like normal light with diffuse foot process effacement and a little bit of ATN.
Yep.
So, Bill, how do you? What would you do with this person?
Well, I'm thinking that the fellows that were on the wheel were like, why does Dr. Rodby get the biopsy that's basically normal, and we get these other biopsies where they're so complicated, lobular and MPGN, and tough lupus cases and reduplication. But I guess that's the nature of the wheel. So
I'm the program director. I can weight it down. So,
I mean, the key here in this case is to really think and try to determine if it's secondary related to the thymoma or it's I guess, a quote unquote idiopathic minimal change. If it's idiopathic, the therapy is pretty straightforward. We try steroids, high dose, for depending on the response for at least 2 months. And in adults, we usually extend that out a little bit longer, depending on how fast the response is. And then we look to see if they're, become steroid dependent or frequent relapsers and so on and so forth as time goes on. But, thinking about the pathophysiology, I don't know the incidence of thymoma with minimal change disease, but you would think that minimal change is a T cell mediated process. And the thymoma sounds like it could really be implicated here if it really is recurrent. So I would try like crazy to figure out if the thymoma is active. And if there's other therapies for that might get the minimal change into remission as well. We would think about, I don't know the other therapies for thymoma though, so it'd be a discussion with oncology.
Great. Steve, it might have been 20 or 30 years ago when you wrote that paper, but what was your main findings of minimal change in adults?
The key finding was that it took longer for adults to go into remission than it did for children. And that in children where the definition of non-response is 8 weeks, and with that definition in children, 95+% of children by 8 weeks have gone into a complete remission, and only 5% about that time are non-responders. Whereas with adults by 8 weeks, what we found, and it was independent of age. I mean, we looked at less than 40 and over less and greater than the age of 40, and we found no difference. But what we found was that it wasn't until about 16 weeks that 80 to 90% of the patients had gone into remission. And ultimately, we had over 90% of patients in remission. So the issue we found was that it took a longer course of therapy in general before they would go into remission relative to children. And up until that time, kind of everything, including the definitions of frequent relapser and steroid dependent, was based on the data from the International Study of Kidney Disease in Children. And so this was kind of one of the times where we and Stuart Cameron and others actually kind of had similar observations around the same time, was that it took a longer course of high dose steroids, and by high dose 60 to 80 milligrams per day, before they'd go into remission. And so you wouldn't give up on them after 8 weeks, and not that we would give up on a child, but by 8 weeks, you couldn't feel that the patient was, or you couldn't find the patient as being non-responsive because you had to treat them longer. That was really the big issue. And part of the thought was, not to belabor this, but in children, the dose of prednisone is based on a meter square basis. So kids get initially 60 milligrams per meter squared, which is a bigger dose than a milligram per kilo, which is how adults are. So one of the thoughts was maybe we were underdosing adults relative to children. And the other issue is that again, maybe adults are just a little more resistant to therapy than kids, but ultimately the response rate was comparable.
Steve, obviously in membranous, we talk about the differences histologically between secondary and primary, not just with PLA2R, but the other features that we talk about. For example, in lupus, if they got mesangial hypercellularity and tubular reticular inclusions and so on. In minimal change, are there any features on biopsy, histologic ones, that could help differentiate primary from secondary?
Not that I'm aware of, with the exception of, and that's a good point, actually. I mean, it's a good point for a couple of reasons. With NSAIDs, if you see interstitial nephritis, especially with a lymphocytic infiltrate, which is what you predominantly see with NSAIDs, unlike with other forms of drug-induced acute interstitial nephritis, which is usually eosinophilic for things like penicillin, sulfa, etc. If you see that a lymphocytic infiltrate and acute renal failure, you always start thinking about NSAID-associated minimal change disease. I'm not aware per se of lithium or lymphomas, or if people have gotten, interferon, whether that there's some kind of heralding finding. But what there was a nice paper that came out several years ago of minimal change in patients with lymphoma. And my recollection is they're much more resilient to treatment. And as was already alluded here, especially in this woman with thymoma, you want to make sure that she doesn't have some sort of a lymphoproliferative disease lurking. And in it, whereas in children, that's highly unlikely that there's a secondary cause of their minimal change disease, because they're usually only 3 or 4 years old when they present and haven't really lived long enough to have these problems per se. The adults is something you really have to consider. And so I think in her case has already been brought up, looking to be sure that this thymoma or that there's not another lymphoproliferative disorder post her chemotherapy lurking is something that at least should be entertained and ruled out.
Oh, go ahead.
So, you made the strong point that it can take longer, but I've had a number of adults with minimal change disease that have responded like a child. Do you remember, is it bimodal? Some respond right away, or is it just kind of some at 2 weeks, some at 4, some at 8, and some at 12?
Well, that's right.
I don't mean to put you on the spot, but I mean.
No, and I've had that experience too. Where some within a few weeks they'll go into remission. We didn't find a difference with the break point being 40 years of age. I'm trying to remember if Cameron did, that people, I think in theirs, the break point was 45, that the younger patients seemed to go into remission quicker than the older, but we didn't see that in our experience. But there's no question, it's not like everybody goes out, when we've talked about this with focal sclerosis, it's not as if they go out and they're nephrotic and all of a sudden at 16 weeks they become they go into remission. I mean, there are patients who will, there obviously people are going into remission by 8 weeks. Half of them will be in remission by 8 weeks, and it's not until about 16 weeks that more than 90% or 80% are in. So definitely there are patients who by 8 weeks will go into remission. And like I said, that was probably the median. And yeah, I mean, we do see that. And then the whole approach therapeutically with those patients, I mean, it's not like you just continue them for 16 weeks. Each person's different. If someone goes into remission relatively quickly, then the question is, what do you do at that moment? Once they've been in remission, do you start tapering them then, or do you continue them on therapy for a while? And that's one of these things that's kind of been discussed. And I think the new KDIGO guidelines addresses it as well. I mean, in my particular practice, I'll keep them on once they've gone into remission, by definition, having less than 300 or 500 milligrams per day of proteinuria. I won't just start tapering them immediately at that point. I'll actually keep them on the same dose of prednisone for at least another more often than not, for at least another month. But yeah, you're right, Roger. I mean, there are some of these people who will go into remission within a month. It's not everybody that has to have 16 weeks worth of treatment.
So the real question here is that when you have these odd secondary FSGSs, I mean, I think it's ironic that I'd never seen a lithium-associated minimal change disease until Dr. Gashty, and I've never seen, I don't know if this is thymoma related or not, but I've never even come close to one. And this is also Dr. Gashty's patient, so I think he's the secondary minimal change doctor now.
Onconephrology.
Yeah, onconephrology, exactly. Good point. And the question is, with these secondary, do you still treat with steroids, or do you just try to get rid of the offending agent? And is there anybody here that wouldn't automatically just give steroids, or that they would try to assess the thymoma first?
I also think it's interesting that your first line therapy typically for lymphoma, and that obviously it's not thymoma, but I almost am lumping them together, is Rituxan. And then there is some data that Rituxan could be good in minimal change as well. Obviously that's talking about typically the ones that are relapsing or frequently. So there may be a role for, for sparing them high dose steroids if you can get a quick idea of if their thymoma is active or not, and getting a little bit more targeted therapy than the bucket of water or steroids pouring on the patient.
It's interesting because, Rituxan is as you mentioned, is a really, really good drug for steroid dependent or frequently relapsers. And there is almost no literature on it as a primary therapy because steroids have worked, they work fast and everything else. But there's reports, but I don't know of any trial where anybody's used it as a primary therapy, probably because you don't want to wait long enough. But I don't think there's any reason to believe it wouldn't work. If it works to keep it away, why wouldn't it work to make it go away? But, I think with lymphoma, it's an interesting thought that you go directly that. But I'm going to hand it over to Dr. Gashty now, because he's going to tell us what he thought about this and what he thinks about the thymoma and secondary FSGS.
Yeah, so, Casey, I'll give you control. Go ahead.
Minimal change.
Actually, while you're setting that up, the one thing, Roger, you bring up with secondary forms, I mean, with minimal, with NSAID associated, you stop, if they're not in acute renal failure or too symptomatic, stopping the NSAIDs is enough sometimes, and within a few weeks they're in remission. In the more severe ones, you will treat them with prednisone as well as stop the NSAIDs. But I think, in most of these cases, you want to treat the underlying problem as far as the secondary forms of minimal change disease, not unlike other renal associated diseases with secondary causes.
So the first thing that I did when I got the biopsy result was to call oncology and ask them what they thought about the CT findings now compared to 2 years ago after she completed her treatment. And the opinion of oncology was that those lymph nodes that were there, the pleural thickening, which had previously been biopsied, and the pleural effusion, which had been previously sampled, both of them were negative, and that there had been no changes radiographically in her mediastinum or around her lungs, and that some of the lymph nodes were calcified, indicating that this has probably been going on for a long time. So they felt pretty comfortable saying that her thymoma, it has not relapsed, but with the caveat that they're going to bring her up at tumor board and they'll discuss her. And so I'll get to that at the end of my talk. But basically, they said they didn't think that she had active disease as far as thymoma is concerned, and that I could proceed with whatever I needed to put her on for treatment of her minimal change disease. So I went ahead and put her on prednisone. And I'll give you follow-up at the end of my talk. So just a quick note on minimal change. Dr. Whittier brought it up, and I think Dr. Corbett alluded to that. There has been almost a 5-decade theory that minimal change disease is a T-cell mediated disease. And the very simple theory, and there's nothing simple about the immune system, but the simplistic view of this is that the dysregulation in T-cell clone will lead to some kind of a lymphokine. And there have been many molecules as a candidate for what the T-cells can produce that cause a permeability factor. Hemopexin, angiopoietin like 4, IL-8, IL-13, all of them have been sort of thrown out there. And that in turn causes a podocytopathy and leakage of albumin. So that's kind of a simplistic view. And the reason this theory came up back in 1974 was because of several, I guess, circumstantial evidence. These were observations that minimal change occurs as a paraneoplastic manifestation of Hodgkin's disease. And Hodgkin's obviously is a B-cell lymphoma. It's a Reed-Sternberg cells are B cells. And so why are we talking about T cells? And I'll go into a little bit of the interaction between B cell and T cells. Some of these T helper cells, they're helping stimulate B cells. So when I think of T cell, B cell interaction, T cells help stimulate B cells. And so there is that balance between B cell populations and T cell clones. The other observation was that patients who had some kind of a thymic disease, whether it was a malignant thymic disorder, thymic hyperplasia, or even myasthenia gravis, there had been cases of minimal change disease associated with thymic disease. And thymus is where T cells mature and then get released into the circulation. The other piece of evidence was that steroids, which in general abate cell-mediated response, treat minimal change disease very, very efficiently. And finally, they had noticed that patients or children who had measles had remission in their minimal change disease, which was kind of ties back into the whole hygiene hypothesis, which was really proposed to explain the increases in allergies in some of these Western industrialized countries. And the hypothesis was that as a child, if you're exposed to a lot of germs, whether these are bacteria or viruses like measles, like hepatitis A, or if you were immunized with like BCG, for example, then you tend to have a certain clone of your T helper cells, which would be, for example, Th1, that would be sort of your Th1 clone would be normal, your Th2 would be elevated. And so if you look at epidemiologically in industrialized countries, there's a difference in the prevalence of specific genes, like for example, MPGN is much more common in developing countries, and minimal change disease is much more common in industrial countries. So Th1 has been associated with MPGN, and predominantly Th2, T helper cell 2, has been associated with minimal change disease. So the same sort of a hypothesis of what you've been exposed to and where you get allergies seems to pan out epidemiologically, although those are pretty loose associations, and no one has really actually proven over the last 47 years since this hypothesis has come up with that permeability factor protein, nor have they really identified a sort of a smoking gun connection between T cells and minimal change disease. But this is basically a series of observations that have proposed that maybe there is a role for T cells in minimal change disease. And this diagram from New England Journal shows you that there is certainly a T cell B cell interaction, and the T cells can differentiate into a balance of Th1, Th2 cells, which can secrete these lymphokines like IL-13, or differentiate into Th17 and T regulatory cells, which would not. And what we don't know is what this soluble mediator that would eventually cause a podocyte to efface is. And this B cell T cell interaction is partially the explanation for why rituximab may work in treatment of minimal change disease. So the paper that Roger you brought up was from 2014, looking at overall about 30 people, about 10 of them were children and 20 of them were adults, who received rituximab for treatment of either steroid-dependent or frequently relapsing nephrotic syndrome. And if you break it out into kids versus adults, there's a significantly reduced number of relapses per patient per year after you receive Rituxan in kids and in adults. And of those 30 nephrotic syndrome patients, if you break it out, there were 22 of them who had either minimal change disease or mesangial disease, and as opposed to 8 patients who had FSGS. But either way, you can see that Rituxan works in these nephrotic patients via its B cell effect, which could subsequently affect the population or clone of T cells, and it would essentially have an indirect effect on the nephrotic syndrome. The case reports that going back to the connection between thymoma and minimal change disease. Minimal change disease is not the only nephrotic syndrome that has been reported, although it is the most common one. These are 20 cases of patients with thymoma who developed nephrotic syndrome. 19 out of the 20 had a biopsy, and 11 of them had minimal change disease, and the rest of them had either membranous or FSGS. And what was interesting to me was the time from the diagnosis of thymoma until the nephrotic syndrome presented could vary from simultaneous presentation up to 13 years later. And they did not really have to have relapse of their thymoma. So you could actually be in remission and 4 years later develop minimal change disease. The mechanism of that is beyond my understanding, and I'm not really sure if anybody understands it, but if they do, they can obviously chime in here. So a lot of these were non-recurrence of disease with years later coming with minimal change disease. And that may or may not be the case with our patients. So we'll kind of have a discussion at the end. So this to me was very interesting. And some of these were concurrent. Some of them were 1, 2, or, in one case, it was 13 and a half years later, the patient presented with minimal change disease. So the closest that we have come to actually look at the clones and what kind of clones are affected by thymoma was this one case report where they actually looked on the top row. They looked at before chemotherapy that was directed at the thymus, at the malignant thymoma. They looked at the population of specific T cells. And so this was cycle 1, day 1 before the chemotherapy. And the bottom row was essentially looking at cycle 2, day 1 pre. So after one cycle of chemotherapy, there was a significant reduction in a certain population of these T cells. And this particular patient had a very resistant minimal change disease. And so they did a thymoma-directed therapy. They used cyclophosphamide. They used cisplatin, they used doxorubicin, and I think they also used belinostat, which is one of these histone deacetylase inhibitors. So this was 4 different chemos directed at the tumor, and finally this patient responded. But the interesting thing was that the response followed this change in the clone of T cells. So again, may not be that smoking gun we're looking for, but at least there's something that points towards that. So I started our patient. This is a graph of what happened to our patient. The black line here is the proteinuria. She started with 10 grams. We started on prednisone 60 milligrams. A month later, she's less than a gram. She did develop AKI, probably due to ATN. Some of that was seen on the biopsy, and that fortunately resolved. And her creatinine is normal now. Her albumin has come up, and her proteinuria is at about 600 milligrams per gram on a ratio. So her quick response to prednisone makes me favor that this was primary minimal change disease. When I spoke to oncology, they said they have about 300 cases per year of malignant thymoma, and the association minimal change is quite rare in this population associated with thymoma. So they weren't really sure if there was a connection. The response to steroid here supports that it may not be connected. But then again, the timeline doesn't really tell you anything, and it doesn't have to be a recurrence of disease. So they went back to the tumor board, and they basically said, okay, let's see if we could do a VATS procedure and maybe biopsy one of the lymph nodes. So right now, that's kind of where we are. They're having a discussion with the patient. The patient's a little hesitant because she's getting better. And so she may be a little hesitant in actually undergoing a lymph node biopsy, but that's something that's still ongoing. I personally don't think that, she has recurrence of thymoma based on radiographics, but I think I would be comfortable in actually having a tissue diagnosis of a benign lymph node to confirm that she doesn't have any active either lymphoma or recurrence of thymoma. And her response is very comforting. So from my standpoint, I'm going to continue this for probably a few more weeks, and then I'm going to slowly taper them with the idea that she's probably going to relapse at some point, hopefully not, but and if that's the case, I always have Rituxan in my back pocket.
That's great. So she really did respond very quickly, like a minimal change, like an idiopathic minimal change, but that doesn't rule out the thymoma. I mean, I think it's absolutely fascinating, that table, that there's, first of all, that many thymoma nephrotic syndrome reports out there, and that it can recur that much later. You have to wonder, is it has just a pure coincidence that some people with a thymoma 10 years later gets minimal change? It's kind of hard to believe not, but you never know. There's a lot of memory in some of these cells, and who knows? Anybody else have any thoughts about treatment?
I like the idea of the Rituxan with the B cells and the T cells. We think about the same thing with ANCA-vasculitis. I mean, we primarily think, why would, similar with Rituxan. So it was a nice discussion. Thank you very much.
Great. Well,
I have one other question. Would you think about hitting her with Rituxan at all, just to prevent relapse, because you were so worried about it, or are you still just going to kind of wait and see if she relapses, considering her disease was so bad with the AKI and everything?
Yeah, I don't know if I would give her Rituxan now. I think I really, there's no data to support it, but I hear you. I think what I would probably do is I would taper the steroids. If I see any hint of a relapse, I'll probably put her back on prednisone and then hit her with Rituxan. With the idea of steroids kind of putting her into remission right away, and then Rituxan would be sort of the long-term kind of keeping her in remission.
I know the guidelines. There are, Steve, you may know the guidelines for using either Rituxan or Cytoxan. I know that about 50% of people will have at least one relapse of minimal change disease. I hope I have that right. With that in mind, most people wait for that second or third relapse before they give either cyclophosphamide or Rituxan. Is there a specific guideline? I mean, I'm with Casey. If I see it coming back, I think the writing's on the wall. But what are your thoughts, Steve?
Well, I mean, it's, frequently relapsing or steroid-dependent nephrotic syndrome with minimal change disease is, it depends upon who you look at. It's about a third of the patients. So, and that's defined. I mean, I think the importance is how it's defined. So if somebody's steroid dependent, it's basically defined by having a relapse at least twice during the taper or within a month after stopping the prednisone. And so if you're coming down and the patient relapses, I don't know if anybody would wait necessarily for the second relapse, but or you stop it and they relapse within a month, then that's basically defining a steroid dependent patient, whereas frequently relapsing is defined by 2 relapses within a 6-month period or 4 in a year. Everyone else.
2 relapses is your third episode of nephrotic syndrome then?
Well, No, a relapse is a relapse. A relapse.
No,
is
no, but after two, you've got your primary and then two relapses. So you've
That's
now
right.
been
No, that's
three
right.
times. So I think Casey's point was, and my point is that, and I don't know if be justified or not, but I don't know that I'd wait for that second relapse.
Well, about half I guess it's just a matter of, I guess, what your preference is. Half patients, once you've treated them, will stay in remission. I mean, 60%, or less than half, 60% will, have a relapse, or I'm sorry, 60 to 70% will have a relapse, but not all of those people will be frequently relapsing or steroid dependent. Some of them may never have another relapse again until a year or more. And so, I guess
you could also make the point, it may not be a year or 2 years, but if you give them a medication that goes 5 years, you've avoided a whole nother 3 months or 2 months of steroids and the toxicity and the bone problems. I mean, there's something to be said. Nelson Lung considers he considers minimal change disease a chronic disease. And when they treat chronic relapsers or steroid dependent, either way, I agree it's a kind of an arbitrary distinction. They don't give one dose. He gives a dose every 6 months for several years. And I think that's an extreme. I don't know if that's completely supported, but that's an opinion that this is, that keeping these patients in remission is far superior than, as a maintenance therapy, is far superior than intermittent doses of steroids, even if it is every two or 3 years.
Well, I mean, again, it depends. I have one particular patient that comes in mind right now who, relapsed, became a steroid dependent patient. We gave him basically one dose of Rituxan, and he's been 2 years out now, and there's been nothing happen. We've given him no more. Yeah. And I guess if you want to just continue to chronically treat him, you can. I don't know that any of us know what the downstream effect of that's going to be yet, because I don't think there's that much experience. I guess there is in lymphomas, but in minimal change disease, at least, and other steroid responsive forms of renal disease, I don't know if we have that much experience. I mean, the KDIGO guidelines, the new ones, basically talk about oral cyclophosphamide still for 8 to 12 weeks and frequently relapsing steroid dependent, with Rituxan as another option. I mean, that was just updated in 2020. I think most of us would be much more comfortable with using Rituxan at this point, given the data, but there's a hell of a lot more data out there with cyclophosphamide still than there is with Rituxan.
It is amazing how Rituxan standard of care, if you will, has gone way. It's so far ahead of recommendations because it takes years for recommendations to come out, and people's experiences have kind of trumped that.
But these recommendations came out in 2020, and the paper that Casey was referring to in Jason came out in 2014. And so we're talking, and there are a bunch of other case reports that are out there as well in steroid dependent or frequently relapsing, which I think is the caveat. It's always that group that they're talking about. If people want to use it in a different manner, I mean, that's obviously a preference, but anyway, I'm sorry, you were getting ready to say something.
And I've had quite a bit of success with, 2 months of oral Cytoxan. It's well tolerated. It's easy for the patients to take. It puts them in long-standing remission. I've got, several patients who are 10, 15 years out after that, and they were frequently relapsing all the time with the steroids. So it definitely works, and it's usually well tolerated in our hands, but I do understand that Rituxan is out there as well. But my first line still for my frequently relapsing or steroid dependent nephrotic syndromes, whether, in FSGS or minimal change, is still cyclophosphamide.
Wow. You're Rituxabil.
I'm Rituxabil.
Yeah, I mean, the KDIGO guidelines, the 2020 ones talk about infrequent relapsers, which is everybody that isn't the steroid dependent or frequently relapsing. And they basically, and this is in the previous guidelines as well, is just go back to the same initial dose of prednisone and then taper them off over a quicker period of time. I've had patients who relapse, once every couple years, and you give them a short course of prednisone and that they're in remission again for, 2-3 years or whatever. Everybody's obviously different, but
let me ask you this, because you say a short course of prednisone, but you stressed earlier you don't want to taper it too quickly, otherwise it's more likely to relapse. So is it really a short course, or is it a longer course?
Well, it's interesting. I would do it generally over a longer period of time, but the KDIGO guidelines basically say the initial dose until they're in a remission and then taper over 2 months. Whereas, the initial therapy in the KDIGO guidelines is, they basically, the newer guidelines, which I think are better, they say once you go under, you treat them with either you treat them with either 1 milligram per kilo per day, up to 80 milligrams daily, or 2 milligram per kilo per day, alternate day, which is kind of the Jerry Appel's, paper with Waldman. You give them at least a minimum of 4 weeks and a maximum of 16 weeks. And they say to begin the taper 2 weeks after the remission. So they still make the point that you don't just start tapering right away. I usually will hold on to the same dose for at least a month, but they say start to taper 2 weeks after they've been in remission with that dose, and they taper off over 6 months. So it's interesting.
Well, it's no short course then.
That was the initial treatment. The relapsing patients, they're saying to treat with your initial dose that got them into remission. You start with the high dose. Once they're in remission, then taper over 2 months. So it is a shorter course that they're basically suggesting in those patients that are infrequent relapsers, which is defined by the ISKDC, which is kind of what's been adopted for this whole definition. Is everybody else that doesn't fit into the classification of frequent relapsing, which is one definition, or steroid dependent, which is another definition.
Yeah, well, that's great. There's a really good discussion and a really, really amazing case. Thanks, everybody. And Dr. Gashti, once again, a really, really enlightening discussion of some pathophysiology. Great job. We will be back next week. The activity code again for this week is 481509. Everybody stay safe, and we'll see you soon.